roundtable here in Las Vegas, Nevada. I'm Dr. Jeff, and we're going to go around the table and introduce ourselves. I'm Dr. Jeff of Recelebrate here in Las Vegas, and we have with us today
Elizabeth Tringali from Tringali Vibrant Health in Palm Beach Gardens in West Palm Beach, Florida.
Josh Black with Becoming Young, longevity coach and strategist.
Hi, I'm Dr. Elizabeth Yurth, and I have a clinic called Boulder Longevity Institute in Boulder, Colorado, and also we have a teaching arm called Boulder Academy, and I'm honored to be here with these guys.
Well, the honor is mine to have you. Thank you for everyone for coming and letting me be the host this time. Maybe someone else will pick up next time. We wanted to get together people of various expertises throughout longevity and wellness and anti-aging and medicine 3.0 and pulling further and further away from the sick care system to the extent that we can. Of course, we still do see people who have problems and they may be considered sick. So we have no specific agenda, but want to talk about a number of different things. So I wanted to open up with inflammation. We use that word, I'm sure, in our practices all the time. And I want to throw it out, and I'll throw it out to you, Dr. Yurth, first. What does inflammation mean? How do you explain it to your patients? And now that you've been treating inflammation or helping address or prevent inflammation, what does it mean both in a general sense and in a scientific sense?
Well, I know we have all these parameters that we've established for aging, right? What are the things that go wrong with aging? I think if you kind of narrow it down to the one big thing that causes almost every disease, it's going to be disruptions in our immune system. So as our immune system starts to go awry, and we can't recognize what to attack and what not to attack, and we actually start attacking ourselves, and we can't attack cancers, then we get sick and we die. So that disruption in the immune system, which is played by a whole bunch of things, our disruption in hormones and peptides and lifestyle and all those things, that disruption and the change in our T-cell metabolism and the T-cells that we make and release from our bone marrow, is probably at the root cause of everything. And I think if we can actually focus on getting the immune system healthy as your number one priority, you're going to be preventing osteoarthritis, you're going to be preventing dementia, you're going to be preventing cardiovascular disease, metabolic diseases. And I think it gets a little bit ignored. We start treating those diseases, even this functional medicine capacity where we're like, okay, well, we don't treat disease, we treat the problem with the disease. We need to go deeper than that. We need to go back to the cell. At the cell, it's that loss of the immune cell function that creates this chronic inflammation, what we call inflammaging, as you guys all know. And that's where we need to begin.
Is anyone else doing any other testing, whether it's blood markers or something else, to look at different ways to measure inflammation?
I think that's really hard, right? Everybody's looking for these magic numbers. And I love you do these big panels, I do too, but I think we have to start looking at how do we democratize this. And I think most doctors don't even understand some very basics. Like you can look at a profile of what is your neutrophil to lymphocyte ratio. It's an easy thing that every one of you guys has on the very basic labs that every doctor does. And that neutrophil lymphocyte ratio should be somewhere less than 1.5 to 1. If that's changing, which happens as we age, if we're starting to see this drop in lymphocytes, this increase in neutrophils, there is something going a little bit awry in your immune system. It's subtle, but watch. You'll see people as they age, that ratio gets worse and worse and worse. And then simple things like when you look at the monocytes and eosinophils and basophils, those are all inflammatory cells. Less than 10% of your white cells should be in that state. So less than 10%, you really should have less than 6% monocytes. You add up that neutrophil and lymphocyte percentage. You guys all have this on your easiest little test. It costs you $5. Add up the neutrophil lymphocytes. They should be 90% of your cells. If they're not, there is something subtle going on. And I'll tell you, most people it's not, because most of us are normal. So I think we have to start looking a little bit at, there's so many expensive tests we can get on people. What can we do with some very basic tests that give us still so much information? Especially like I'm sure the clients you deal with, right? They're just coming to you with some very basic stuff. And that's something very easy that they can look at to determine.
And the great thing about that, right, is that it allows for the frequent testing, right? So we can get that data.
Right?
Yeah.
So instead of a $500 test that I'm doing. Right?
I mean, it's all about tracking those small changes because the small changes compound, right? So I always talk about looking in the mirror. Like when I get up in the morning, I'm looking in the mirror every day. I'm noticing those small changes because I'm looking at it every day. But if I'm not looking in the mirror, one day I'm going to wake up and I'm going to go, man, like all of a sudden I got these bags under my eyes, right?
Right.
So I like to be...
Or like looking at weight, right?
Yeah, exactly. Same thing. So I think that's really important not to have the expensive tests that you have to run over and over. You can get those quick. You can get them easy and do them regularly.
And they give you a lot of information. They really do.
Even looking at the chemistry, right? Like you look at the bilirubin, look at the ALT, the AST. That's definitely
ALK phos. If your ALK phos is going up, it's a marker. The mean cell volume. Nobody looks at the mean cell volume, the size of your cells. if your immune cell volume is increasing, if those size of your cells is getting bigger, then your autophagy, you're not getting rid of older cells, you're collecting more damaged cells. And nobody looks at immune cell volume. It should be less than 92%. So there's these very simple things that we've just ignored. So we do have to be careful about that,
Yes,
right? That we're overlooking the big things, following all our little gauges.
Yeah.
As we're talking about inflammatory markers and senescence, I sort of have been wondering, what are you guys testing to test for senescence? I know that this is a challenge, right? And I don't want to lose the forest through the trees, like you just mentioned, but I'm sort of just interested to hear what you guys are thinking on that.
Simplest marker we have, if you want one test, is going to be a beta-galactosidase. I think that's probably the easy one test. There's a lot of multifactorial tests. That's the holy grail. What is our one? Like we're going to come up with the best test that shows what everybody's senescent cell burden is. I think the problem is that changes a lot, almost day to day. I think like a lot of tests, sometimes you're chasing your tail a little bit on it. So I do think beta-galactosidase is a reasonable marker to look at. But like you said, Elizabeth, it's just, once all the basics are fixed, you can assume that probably senescence is getting better. And then we do we just put a lot of people on things that are autophagy-inducing agents.
So, okay, we know we've got inflammation. We know there are ways to measure it. Let's say you've got the enthusiasts. They're healthy. They're eating right. They're sleeping right. They, turn off their screens a couple hours before bedtime. They've got it all dialed in, but they're still not right. They don't have the energy. Something's not right. And maybe you have some markers in basic bloods or advanced blood testing. What are the add-ons? What are the special things we're doing now that you've seen move the needle for people?
Well, as Elizabeth said, we always go back to the gut. So if I have somebody who's not doing well, I go back and look at their gut because more than likely something's wrong with their gut that's instigating that. So you've got to go back and repair the gut and see what's going on with the gut. Now, once we've gotten there and we're like, okay, yes, we've got this inflammation, we fixed the gut, you're doing everything right, what are some next steps that we can go to? Honestly, if I look at the number one thing that's going to be the best thing you can do for your immune system, maintaining hormones. People love their peptides. I love peptides. I see people coming in for 10 different peptides and their hormones are crap. And one of the reasons that women fare so much better than men for a long time is because of estrogen. Estrogen is a very immunoprotective hormone, and men need it just as well, right? They get it from their testosterone. So as their testosterone drops, they start losing estrogen. They have the immune dysfunction too. But women, senescent cell burden is delayed until they hit menopause or perimenopause, as soon as their estrogen started dropping. So I think we have to be very attuned. People come into our offices right when they're 50, and they're starting to feel like sex drive is gone and they're getting fat and these things. I think we need to start encouraging this. We're following these things at 30 and we're showing people we need to address it. How do we get the young people to start looking at this? Now the studies show, the Stanford study in cardiovascular, the earlier you can start replacing the hormones, the better off you're going to be.
In Florida, you really have to look at all these other toxins that are really affecting the hormone disruption. Chris Shade and I just did a podcast, and he talks so much about you have to get those receptors to wake up and utilize the hormone properly. And I used to have a friend who in a med spa, and she referred all these hormone patients to me because she wanted them to look good on the outside and the inside. Would do the workup, and she'd get mad at me, and she's like, "These patients are upset that you're checking them for toxins and deficiencies. So, they don't want that. They just want to go on hormones." And I'm like, you have to understand they will not get better. So I'd lose half of them, but the other half would stay, and they would totally be vibrant and shine and would have a much better result than just taking the hormones that I used to prescribe and not knowing better.
Yeah, interesting. Vibrant Lab, I don't know if you've seen it yet. Vibrant Lab, we got a little early sample of it, but just released a urine test that not just tests the hormone, but it tests some of the gene SNPs, it tests all the toxins, it tests receptor disruptors.
Beautiful.
So all in one urine test. That doesn't cost much more than a Dutch test. All that information in one piece. It's really close to being released.
Thank God, because the urine toxic test is almost
right,
for $470 or something.
So now we have a test that we can look at all of it one place. So it's really cool.
And we were talking about female hormones, of course, because
we're more important.
Obviously. But we couldn't carry on, right? We need mothers. There's this controversy, and I think we're all assuming here at this panel that we're beyond the myths here. But for those of us, those people who might be watching who don't know, I think we're pretty well re-educated now that the risks of breast cancer and ovarian cancer and things that are perhaps related to these abnormal, non-bioidentical, conjugated estrogens and progestins and things has now been demonstrated to be largely a myth debunked. Does anyone want to comment on?
There's this myth that you have to get these bioidentical hormones from a compounding pharmacy, right? And you don't. I mean, estradiol is estradiol.
Same thing.
Estradiol is bioidentical estradiol, and the compounding pharmacists kind of propagate this myth. But I hear functional medicine doctors saying that all the time. So when I put someone on an estradiol patch, they always go, well, this is not bioidentical. It is. Estradiol is estradiol. Progesterone is progesterone. The big downside of the prometrium is it's got a peanut oil in it, so you have to be a little careful with it from an allergy perspective.
Right.
And it's not too late if someone's postmenopausal and they want to help their bone density, reduce their cardiovascular risk, reduce risk of dementia, lowered inflammatory factors that go with that. Start at a later age. That's okay. Anyone have problems there?
That myth is way going on still, right?
Yeah, it's too late.
Oh my God, it's too late to start, or you don't need these anymore. I mean, I get that all the time from my patients who have been on hormones with me, who trust me. They go, my doc said I really don't need these anymore. I'm like, why? Because you should die? That frightens me. It has to do with some of our ageism. And, what we'd like to see is everybody working hard and doing things at 90, right? That's, I think, a myth that still is going on and on and on. And yes, it's better to start early, but it is never too late.
It's never too late. Right. Like a senescent cell, we don't want senescent people. So.
Right. God. Also, you brought up the word biased, and I'd love to hear your opinion on biased.
I use more estradiol because I do honestly use the patch more. The estriol is very weak.
Right.
I like it for lubrication. I'll use it transvaginally. I rarely will prescribe the biased cream. I used to. That's how we were trained with
A4M.
That's how we were trained, yeah. A4M fellowship. Everyone goes on biased, 80-20, 50-50.
Right.
It didn't work as well as just straight estradiol. Everyone was still dry. They were having the brain fog. They were still having hot flashes. And they would go to their gynecologist and they would put them on Premarin over the biased because it worked so well. So then when I switched to estradiol, I liked it better.
Right.
What do you think?
So, like you, I was trained in biased, right? Which biased is 80% E3, a very weak, ineffective estrogen, and only 20% estradiol, E2, which is really what you need. So it was kind of tippy-toe because we're not going to do anything bad with estriol. It's not going to do any harm, but it also doesn't do any good. I will tell you, over time, the data that's coming out on estriol is actually becoming more and more negative. That it actually impedes the ability of the estradiol to then sit in the receptors and actually have its effect. Even if you add it in at sometimes a low amount, it may be to detriment to the patient. It also appears that it may be more linked to some side effects like breast tenderness and things like that. I love it as a face cream.
I love it.
It's great for face cream. I love it for vaginal stuff, for vaginal lubrication. I think it's great. People need to sort of abandon the biased myth. It's still very being taught. I think if you look at the data, you need to be sticking to primarily estradiol. We're seeing that trend change a little bit, but I still see a lot of women on just a lot of E3.
It's what they're training still.
Right.
Are you on just straight estradiol patch, or are you do?
I just do estradiol patch. Yeah. I mean, speaking on testosterone on men, have any of you guys been using Kaisertrex, the oral testosterone?
No, but tell us what you know. They were at the booth next to us in Austin. What can you tell us?
So Kaisertrex is interesting. It's the first oral-derived testosterone that's designed to be absorbed through the intestinal lymphatics. By doing that, it doesn't have any effect on the liver. If you think about what happens, our concerns with testosterone in younger guys, right, is that testicular suppression. So we know that if I have a young guy who has low testosterone, I have to make sure I'm keeping his testicular function up using HCG or clomiphene, something to keep his testicular function up. Because what you do with Kaisertrex is you take it twice a day, it is very physiologic. So the reason you get the suppression of testicular function is because you have these very high levels that you're sustaining for a long period of time, which isn't really the way physiologically you make testosterone, right? Your testosterone does this, it drops down. Kaisertrex, because it's short-lived in the system, is much more physiologic, and you don't see the suppression of FSH and LH. You don't see a reduction in spermatogenesis. You don't see testicular atrophy. So it's a much safer alternative for younger guys. And for my guys who just are tired of doing injections, it's worked quite well.
And does it drive the numbers where they want to?
So the hard thing is
testing
it, right? Because it's going to be short-lived in your system. You have to get them to go in 3 hours after their injection, because 3 hours peaks, at 6 hours is down, you hit it again. And so if I can't just go, hey, go get your blood test in the morning, it has to be timed with that. So otherwise, it will look low oftentimes. If you can get them to test it right, it does work great, right? Now, I do find some of my more bodybuilder-y guys who want super, super physiologic levels of testosterone, and that's just where they feel great. I probably can't get to those kind of levels. But for physiologic levels, it can do quite well. But it's my go-to now for my younger guys. It's just probably so much safer. And, I think we like to do everything a little more physiologic if we can.
Yeah.
So are you getting levels that are 200 or 300?
With the oral Kaisertrex, I can get my total testosterone up into the 1100 range.
Oh, that's
3 hours after taking it.
3 hours after taking
it. Have
it.
you used the ones from Quicksilver, the prescription liposomal? And I think there's also PD Labs now from Jim Lavelle. Have you used any of those?
Maybe they work. The only people who've gone through the regimented testing to see that these truly are absorbed through the lymphatic system. There's no other involvement, and that they truly do not cause testicular dysfunction is Kaiserix, and they have the patent on it, and so nobody else can copy it.
That's good.
So I'm not sure. Maybe those do work just as well. I'm just going to go with something that's gone through the FDA approval.
Yes. I used them just because when they came out, I'm like, this is a great alternative to shots, right? The liposomal forms. But I was testing wrong, and I just found this out because nobody's level was going up.
Right, exactly. I had that problem with Kaiserix, right? It's
Yeah.
like, oh my God, this doesn't work at
Terrible.
all. And then you realize you have to test it.
I just asked my pharmacist like literally yesterday. I'm
Right.
like, why are the needle's not moving? She's like, are you doing it 2 hours in this case?
Right.
2 hours after taking it? I'm like, no. I tell them not to take it because I want to see like what
At the
is
trough,
it's
yeah.
not building up, but that makes sense because it's physiological.
Right, it's physiological. That's how testosterone works in you guys.
You're
right?
not giving a depot
You know.
shot of a cypionate, a synthetic form, right?
Now, they are trying to come out with a female dosing, but I have dosed it, so the lowest capsule is 100 milligrams, which is high for a woman. So, some women do want to try it. I have them freeze it because it's a gel, freeze it, and then cut it in half. And what I found, even personally, I think women are different. We cycle more monthly with our testosterone and less daily. And so what I found on it is a little less muscle build than I could get with real testosterone.
Yeah.
And maybe that's just difference in how we truly make testosterone, right? It's much lower, but we keep a little bit more stable levels. But I don't know, I'm still playing with it because we really don't have the female dosing.
Now, have you seen with hormone management by itself, someone else has already dialed in with most lifestyle factors, have you seen inflammation markers move or symptoms of inflammaging move in the right direction just with that alone?
Definitely.
Yeah.
Definitely. I mean, I think of anything I do, it works the best. You can get so many people better simply with that. It's funny because I did this course called What to Fix First. And when I was writing the course, it was always like, okay, I went through the diet and exercise. It became when I went to the, do you fix diet, exercise, and nutrition first? I actually went to, maybe we have to fix hormones first and then tackle that with them. Or testosterone, you send them to the gym and they have zero testosterone, they're going to be like, I'm going to the gym, I'm doing everything you're saying, it's not working, this sucks, I'm going to go back to my slovenly lifestyle. So I do think we have to be aware of that because I see a lot of health coaches who are oftentimes saying, let's just get all this dialed in and so much will fix it. And I think if you're younger, maybe that does, like if you get exercising, your testosterone levels will increase. But I think we have to be cognizant that sometimes we're asking people to do what they don't have the capacity to do because they don't have hormones.
I always want to test the blood work first and
Good.
take a look because I do think it's sort of like it's easy to say let's fix these things, these foundational things, and they should be
They should be
addressed,
fixed, right? You have to. You have to.
But it's sort of like there's dual paths,
Right.
and you can work on
You
more
have to
than
do
one
both-
thing at a time.
Both at the same time, right?
So, and that's when you add the peptides too.
Yeah, so thank you for transitioning us to, okay, so what are the other add-ons? Or what other things can we do? Someone comes in, they're dialed in on their hormones, in their lifestyle, everything, but they're still not where they need to be. What else can we employ?
I mean, that GLP-1, when that came out, I thought that was a game changer for everything.
Everything.
Neuroinflammation, joint inflammation, autoimmune disease, weight loss, because when you go on hormones, sometimes you gain a little bit of water weight. You really do. Sometimes progesterone can cause even a little cellulite. So when I would add in a GLP-1, it was like, this is Christmas every day. Like in BPC, you cannot ignore BPC 157, right?
I had a personal story with BPC. So when I first started Peptides last year, I had torn my tricep tendon, and after 6 months and rest and everything, I called Jeff and I said, Jeff, do I need stem cells? What do I need to do? And he said, you need to get on triplex, right? You need to get on the BPC, the TB, and the copper. And after 6 weeks, I was good as gold. I didn't do it right in the tricep. I just did it in the belly.
Oh, but
So-
let's talk about that. It comes up all the time
does
with
come up all the
patients,
time.
and it just doesn't make sense to me. If you're injecting, it's being taken into the capillaries, the body's going to get it. So let's start with Elizabeth. You tell us what you
So
think.
totally agree that there's no reason. It's working systemically on you, right?
Right.
Anecdotally, if you look anecdotally, people feel better when they inject close to the site. I'm sure it has something to do here. People say, oh, I felt so much better after I did it. So I do, if you can. Obviously, it's hard if you try, so if you're trying to like do this, I can my shoulder, I'm like, but, I tell people, these are designed to work systemically. If it's easy enough, it's your knee, it's just as easy to stick it right here as it is into your belly. Do it. But the data shows that these are systemic peptides.
Great.
Yeah, it's not like it's a steroid, so you're not
Right,
getting
right,
a
it's
local.
right. It's not a local, right?
Yeah.
Although when I have back issues, I have my husband stick me in my back,
Yeah.
and it works faster. But I don't know if it's in my head.
Do you guys feel
my head.
splitting the dose so that you can maintain sort of higher physiological levels is helpful to you?
Like a BID dose twice a day.
Yeah.
Yeah, for BPC definitely because it has a shorter half-life.
Yeah.
But thymosin beta seems to last longer. And I know you love the pentosin. It burns. Do you add bicarb
Well,
to it? It burns. So I
Just depends on who you get it from. So talk to me about that. VPI pharmacy, I started having them make it. It doesn't hurt at all.
VPI.
Yeah, VPI, Valescent Pharmacy. BPI. They make it doesn't hurt at all.
Can you explain, because maybe people watching one of our channels may not know about penisin polysulfate?
So penisin polysulfate is one of my favorite drugs, and you guys will see this come to market actually as the drug called xylitol. Penisin actually came out in the 80s as a drug Elmiron. That's an oral penticin, and it was designed for bladder inflammation, bladder cystitis. But what they found is those same mechanisms are involved in all sorts of inflammatory processes. So it reduced nuclear factor kappa beta, changed some of the neural growth factors, which is why it's so helpful for like back pain people and joint pain people. It increased vascular flow, so it did everything you need to heal a joint. So one of the pharmacies, Paradigm Pharmaceuticals, who does a lot of repurposing drugs, said, look, this drug does a lot more else. Let's go look at it for joints. The problem with the oral penticin is you have to take it at a pretty high dose. And what they found is after people were on that very high dose for a long time, a small number, but not negligible, started developing retinopathy. If we can dose injectably, will it work better? And we can use it at a much lower dose and not get these toxic levels. And indeed, it works at a fraction of the dose. You're talking about a 500 milligram dose versus 250 microgram dose. So you would need to be on 80 years before it reached toxic levels. And injectably, it worked much better systemically on things like joints. So it's in phase 3 trials here in the US. It's already introduced in places like Australia for treating osteoarthritis. It'll come out only for knees, but it works in all osteoarthritis. It's blocking interleukin-1 beta, which is the big cytokine that's involved in joint and cardiac, which is why this drug helps cardiac too. It's reducing TNF-alpha. If you look at the metallomatrix proteases, so these are these little enzymes that are destroying your cartilage or destroying your disc, blocks those. This ADAM enzyme, it works on every aspect of arthritis. I have horrible arthritis in multiple joints, and I've been on this drug for about 2 years, and I don't have any knee problems anymore. It is remarkable. But it also has antiviral properties, anti-cancer properties. If you take it orally at a small dose, it's really good for the gut, so it has these incredible properties there. It's glycosaminoglycan, so it will help heal the gut. It's really a remarkable thing. It is my go-to for osteoarthritis, and the studies showed at a year, people who were taking this drug had 30% improvement in cartilage. Discs, in a rabbit model, you can regrow a disc back to normal with penicillin.
If we were only rabbits.
And you don't have to take a break, right? You can do it twice a week, long term.
Yeah, twice a week or once a week at a higher dose. It's just easier sometimes to split the dose because it's a big volume, right? And you can do it long term. So the study showed improvement at 12 weeks. I find people just kind of keep getting a little better, a little better, a little bit better the longer they're on it. For me, it's a game changer. And in our practice, it is huge. Post-procedures, to do this because it controls the over-aggressive inflammatory response. We don't want after we do a procedure on somebody, we want some inflammation, but not this overwhelming inflammation, so it controls that. The only downside is a weak blood thinner, so I have them stop it before procedures for about 3 days. But it is really, honestly, I mean, keep an eye on this drug. It will come out. It will get paid for eventually by insurance. Its side effects were less than placebo. I mean,
is there any use outside of systemic or oral? Are people doing intra-articular, peri-articular?
So the problem with intra-articular is that it can create a hemarthrosis, and you know how horrible that is.
I don't know what that is.
So it's blood filling the joint, basically. Okay. So if you put it into the joint, because it can cause this sort of blood thinning effect, sometimes you'll get this blood vessels to bleed too much, and if the joint fills with blood, blood is really painful in a joint. Tried it once, decided never to try it again.
In the regenerative space, we're using various types of biologics for joint health and cartilage regeneration. But I have a respected colleague in Tennessee who has, before that procedure, maybe a couple weeks or 4 weeks before, will actually inject alpha-2 macroglobulin in the
I do
joint.
that. If I get people to pay for it, I always try and do A2M to try and blunt that. And lots of times the A2M cures them because it stops that over-aggressive inflammatory response that they're having ongoing anyway. So alpha-2 macroglobulin, guys, is something that floats around in your blood, and it's like a Pac-Man to sort of eat the little cytokines that are released and get rid of them. And so we have this all over us to go take care of inflammation. And it's pretty cool. It's actually a pretty cool protein. It looks like Pac-Man. And when it runs into these inflammatory cytokines, it binds to them and you excrete them. And if you look at arthritic joints, they have lower levels of alpha-2 macroglobulin in them. So what we can do is take your blood, spin out this protein, so you have to use a special filter that is just for this size protein, inject it back into the joint. Now I've blunted all that over-aggressive inflammatory response. Now when I do my procedure a few weeks later to stem cells or platelet cells or exosomes or whatever you want to do, it works much better.
How much does that cost?
We charge about $700 for the A2M.
It's worth it.
But I think it's the ideal way for us to treat things. I've done intradiscal A2M.
Yeah.
It can be really amazing for intradiscal pain, for people with discogenic back pain.
Without herniation necessarily?
And even without herniation, just have discogenic back pain.
Because it doesn't make the herniation go away, right?
Well, it won't make the herniation go away, but reduces all that inflammatory response.
And there's a lot of that.
And there's a lot of that, right?
Yeah. For you to know, a disc herniation means some of the disc is out of place, and that goes through a tear in the annular cartilage, and through that tear you leak these highly inflammatory enzymes.
Right. And it's super painful. That's why it's so painful, right?
Yeah.
These enzymes get out around the nerve and they're toxic to the nerve.
So you're not fixing the mechanical problem necessarily, but you might be able to turn off the inflammatory pain symptoms, which might be enough.
Might be enough, right. So then the body can go on to heal a little bit, right?
Do you pair alpha-2 microglobulin, pentosan polysulfate with some peptide regimens like a BPC 157, TB 500 plus?
Pretty much everybody. Okay. So everybody's on a regimen of BPC with thymosin beta-4. Before we even do a procedure on, we'll prep them with BPC, thymosin beta-4, and pentosan for a while, and then we'll continue it after the procedure, taking a little break from the pentosan to avoid any bleeding. We also, a lot of times, add on an anabolic like nandrolone. Because nandrolone, if you look at it for joint recovery and joint pain, it's quite dramatic in helping joint pain. It's actually one of the hardest things I have is when I put guys on nandrolone who have a lot of arthritis pain, they feel so much better. Really, you have to cycle nandrolone because it's so anabolic. So they don't want to get off of it because they feel so much better. But if you can use a little nandrolone, the studies show post-surgery or post-procedures, you heal significantly faster. So you can put them on a short course, both men and women, on a little bit of an anabolic steroid as well to help them.
Is intramuscular injection.
You can actually use sub-Q nandrolone, just like you can use sub-Q testosterone.
Okay. So practically speaking, with these different high-end protocols, very few people have access to this.
Right, that's the problem,
there are a handful of people peppered throughout the country and elsewhere that can do them. What can people do that have some enthusiasm, some interest, some access? What's the best sort of ABC protocol for people, you think, with maybe they strained a joint or have a little bit of osteoarthritic pain? What do you think is the best simple way to approach that?
I mean, there's the oral peptides that pretty much anyone can get, and they do seem to work. They have them with a SNAC enzyme now, so it kind of helps it get into that epithelial layer of the gut. Hyperbarics, you can get at any of these places like Restore and Wellness. So, and you could buy your own personal hyperbaric now, fairly inexpensive, and you're not going to do a deep dive like 2.5 atmospheres, but you can do enough to help your body heal. Red light therapy, I mean, people don't really talk about red light. It works.
Red light's huge.
It's not that expensive.
It stimulates mitochondrial function, so you start,
You do a little methylene blue with it maybe, but that's great. And PEMF, the pulse electromagnetic frequency mats, you can get some affordable PEMFs that really help pain.
Or local PEMF, like a little, I just want to have one I put on my shoulder, I put on my knee, that's just a local one. The pulsed electromagnetic fields. I'm actually doing a quantum biology certification right now because if you look at light and energy, it is a huge piece of our health and our mitochondria.
Photomodulation.
Right? So that's why these things work. They get the mitochondria active again, so they help us to heal and recover. They seem wacky to people, and yet there's a lot of science behind them.
Right, and this is not trivial. So for those newbies listening at home, the mitochondria aren't just the powerhouse of the cells. They are so much more. They're probably a cell within a cell. And if you take care of them, you're really going a long way to take care of your cells and yourself. And they are a major source of inflammatory leakage and damage. And if you can maintain those.
Probably the source.
So a lot of the mitochondrial peptides that you talked about, a lot of the other supplements, urolithin A, you mentioned, and a few others, and some of these energy modalities sure work at that level.
Yeah.
And again, there's nothing better than good old-fashioned movement and exercise and strategically.
Exercise is the best pill for everything.
Right.
Where are hormones made? If you ask somebody that question, my testicles, my ovaries, they're made in mitochondria. The inner mitochondrial membrane is what makes hormones. That's why you saw post-COVID everybody's hormone levels dropped, because you knocked out mitochondria. So if you knock out mitochondria, you can't make hormones. And so we put these people on hormones, and that can help sustain them. But when you see that, especially in a young person, you see this rapid drop in hormones, go back to the mitochondria and repair the mitochondria, like what Elizabeth was talking about, urolithin A, SS31, MOD-SC.
So as a sidebar to what you just said, we need cholesterol to make those steroid-based hormones. And when we say steroid-based, we're talking about most of the sex hormones, testosterone, estrogens. The adrenal hormones are based on a sterol molecule, which comes from cholesterol.
Right.
So we're all afraid of cholesterol. My level's over 200, but I don't freak out when someone's 220. So any comments on cholesterol?
You have to look at everything, right? Like your HDL might be 100, and that's going to save you, right? And even if your LDL's high, you want to look like ApoB, because that's like the conglomeration of all the bad particles together. Apolipoprotein B, that's covered by insurance. You need to look at all these other things. The problem is primary care and even cardiologists, they don't do the testing. They don't have the time for the testing. And I don't know, it may be just confusing to the patient in general. But you have to look at so many things.
It's actually good now to interesting study looking at brain volumes, volumetric studies on brains versus cholesterol. And he found that your optimal cholesterol is actually somewhere between 200 and 250. So we are pushing cholesterol down too low, at least for brain volume, for sex. Our brain needs a lot of lipids, right? Agree with you. The ApoB, and I think the ApoB-A ratio being critical. I think the triglycerides is key. That's if you're looking at diet, that's a big player. Diet, triglyceride to HDL ratio. You need the ApoB to A ratio, not just the ApoB. I think you need the ApoB to ApoA. Remember, plaque is really complex to form, and it doesn't just take high LDL. It has to become oxidized, and then you have to have inflammation because these monocytes turn into these are macrophages that then eat the cholesterol, the oxidized cholesterol, and then they make foam cells, and the foam cells are what attach to the endothelial lining. And so at the root of it, if you have zero bad oxidative stress, if your mitochondria are working well, you can tolerate a high cholesterol, even a bad ApoB, even a Lp(a). I think everybody needs a Clearly scan.
I think that's great, yeah.
So, Clearly scan uses a coronary CT angiogram because calcified plaque is actually really not risky. It is like cement. What's risky is soft plaque, and especially what's called very low density soft plaque. It's filled with fat, basically. It's filled with lipids. And so what happens is it creates an injury to the vessel wall. It ruptures off. It travels down the artery, and that's what 90% of people who die of a sudden heart attack are like, oh my God, he was fine. Cool thing about the Clearly, guys, is you get kind of a picture of your artery, and that's scary, right? Also, you see your artery, and they have these plaques. Like they've colored, the AI is colored, so it's got yellow or blue plaque, and you're like, ooh, well, that's scary, right? And it also gives you something called a remodeling index. So the remodeling index is how much the plaque is causing the blood vessel to sort of remodel or sort of stretch outward. The higher the remodeling index, the more dangerous that plaque is. So now we know this is a person I have to address. But our goal would be to not get the plaque,
That's right.
Yeah.
That's right.
Prevent the plaque.
It's like we need people to be looking at their cardiac stuff earlier, not when they're 60.
And I have a question for you for the postmenopausal woman who's, say, 65, wants to go on hormones. Some gynecologist with a menopause was saying, do a Clearly or at least do a calcium score to make sure they don't have the soft plaque because they're concerned if you add the estrogen, it would actually help heal the endothelium and perhaps dislodge plaque. What do you feel about that? Because I haven't read anything about this. This gynecologist told me this. Yes?
That's
okay, good. Because then I was getting all these.
The estrogen is going to reduce the inflammatory response. You're actually going to get less of the remodeling of the blood vessel if you reduce the inflammatory response, or less of this what we call positive remodeling that you don't want. I think that's BS. I'd have to look at the study that they're quoting if they have one, but that
makes me feel better because that was my only concern about someone who's never been on hormones, like putting them on. So I would just kind of slowly titrate them up.
I think you mentioned something that caught my attention there. So I think one of the things that's important when we're putting anything in our body, whether that's a supplement or a peptide or a prescription medication, is to get those before and afters. And we talk about doing the blood work. Just because there are things going on that we can't see inside, and the blood work is our next best friend, right? There is a lot of benefit to working with somebody who understands how to make sure that sequences in the right way, because I don't think any of us here anyway are telling folks just to sort of like take a pill, right, to put something in there. We really want to make sure that we're monitoring. Hey, we can't improve what we don't test, and we can't check what we don't, we're not following down the line.
What do you target your IGF score?
It's so hard. It depends. If you're an 80, I'm going to say, okay, I want you at 150 maybe, but if you're at 150, I want you at 200. But I don't really like it above too high. Mine went to 400 once. I remember.
Wow.
Yeah, and it was not even on any peptides. This is pre-peptides. This is when I was doing bodybuilding and I was on whey protein. And I don't know if I'm just an anomaly or it's because I have insulin resistance, but I was just doing a whey protein shake every day and checked my level just to see. It was 400. I asked my friend, Dr. Mark Rosenberg. He's like, you're going to get cancer. You got to stop. I'm like, okay. He scared the crap out of me.
How old were you?
I was doing bodybuilding age 40, maybe like 38.
My 20-some-year-old bodybuilders will have levels in the 300s and 400s.
But are they on peptides?
No.
So the whey protein, the whey and glutamine, people don't realize glutamine and just amino acids.
And I don't think it's dangerous for them.
Good. That makes me feel better.
I don't think it's dangerous. I'm 40's a little bit older.
Mark.
I do think as you get older, I think you kind of want to hit that 170 to kind of 190 range. But like my kids are all really muscular. I've got 5 kids, and they all have IGF levels in the 300s.
How old are they?
They're young. I mean, they're 20s and all 20s.
And do you think the insulin resistance affects it? Because if you have
none of them are insulin resistant.
No, but I'm just saying, like for me, so I didn't realize I had.
Yeah, that's possible. Yeah, that's possible with you. Yeah, at 40, 400 would be high. But if you're super muscular, sometimes you can see that.
I was really muscular.
Yeah, my bodybuilders will.
time,
Yeah, if you're really ripped, you will sometimes see those very high IGF levels. And I don't think it's a bad thing.
Good. Thank you.
Love that. We've talked about some of the more common peptides out there and for their uses, but there's an explosion. I mean, I can't keep up with the number of new peptides. So what's the latest and most exciting peptides on your desk?
I'm kind of in love right now with SLUP, SLUPP332 right now.
Oral.
Oral.
Okay.
Right? So it's an oral, and it's really a small molecule, not a peptide. It kind of falls in that peptide category, but it's actually an estrogen receptor modulator. When we modulate estrogen receptors just properly, we can really change a lot of things. And for metabolic health and muscle building and endurance, when you stimulate the estrogen receptors, it's something called TFAM, you can markedly improve mitochondrial biogenesis. Where this peptide really has been helpful is in a lot of my mitochondrial dysfunction people, but also like for me, I don't like endurance work. I like to lift weights, but I don't like to do endurance stuff. It helps me a lot with endurance work.
It's an exercise mimetic, right?
It's an exercise mimetic.
So it makes your body think you're exercising when you're not. Like,
So it's really good for burning calories and things like that, but it does give you that more sustained endurance when you do.
Where are you getting that, or what pharmacies? Because I've been having a hard time finding it.
So BPI makes it for us.
This brings up a great question, and I'm sure not myself alone, but people at home are going to want to know. So we're talking about compounding pharmacies that handle peptides. How about not compounding pharmacies? What about some of the online ones? What do you feel about that?
You can't trust them, in my opinion. It's research only. It says it on there. It's research only. There's no third-party testing. You're just guessing, or hoping. I think it's scary. I don't trust it. I wouldn't recommend a patient to do it. Plus, that's my license on the line saying, hey, get this from this place. It might be from China.
In some cases, they're so hard to get that I have recommended people look for research sites that have third-party testing. I understand why they're putting research. They have no other choice.
Yes.
But I've used some of that material. My understanding is, at least in some cases, the compounding pharmacies are actually getting their supplies from similar suppliers. So I don't know if that's 100% true, but because it's so new and out there, it's hard to find compounding pharmacies that can do it, especially locally.
I, as a physician, for me to say, go take a research chemical, my license is on the line. I think we cannot, as a physician, recommend it to our patients. What we found, but a lot did have what they said in them, things like the contaminant levels were much higher when we had an independent lab look at them. So they're really doing a good job of authentication, showing that they have what they in them. They don't do the detailed analysis down to the small amounts of arsenic and lead and things like that. And that's what we found when we took the analysis way down, is a lot more of them had heavy metals in them. So that worries me. I think if you're injecting them a lot and you're doing something that has arsenic in it, it's probably not a great idea.
Well, of course.
But I agree.
Right.
Even I have bought some of them that I can't get anywhere else. It's tough. I mean, have either of you guys ever done something that was like, oh my God, this is the most incredible thing I've ever done in my life? Is there like some peptide you did?
Well, I'm a biohacker, so I've done a lot of crazy things. But
and so there's just something that you're like,
Exosomes.
oh my God, that was like really incredible.
IV exosomes are stem cell derived.
I would say
exosomes.
IV exosomes are probably the closest I've come to.
I've done some HGH. I think when I do that for 4 to 6 weeks, it's a difference maker. Yeah, especially in the gym, adding muscle, especially after some long use of GLP-1s.
Yeah.
Did you think it was better than like a secretagogue, like a tesmorelin or semirelin?
Yeah. Oh yeah. HGH is especially at my old age, it makes a difference. Yeah.
How long did you cycle it?
I will go on 4 to 6 weeks. Go off 4 to 6 weeks.
You do hear that people feel better on HGH than they do on
Yeah.
a secretagogue.
You slept
And I think if you're doing them short term, it's
everything
probably
is
not
better. Sleep, brain, mood, gym workouts, recovery. I mean, it's misnamed. It should be the master anti-inflammatory hormone or something like that, because it just really puts you in.
I agree. IV exosomes is something that you can feel pretty.
Yeah.
IV exosomes are probably the closest I've come on that. I will say, for me, Pentacin is a life-saving thing. Without it, my joints are horrible, because that's probably my biggest thing that is my arthritis. Low-dose GLP-1s, I feel better on. I mean, I just low dose them. I'm skinny, so I don't really want to take too much. I don't want to decrease my appetite. But I think low dose GLP-1s keep my immune system a lot more stable. I never, ever get sick. I always feel pretty energetic. I always feel pretty good. So I definitely feel better on the low dose GLP-1s, and I will never stop those.
And the research is so great on GLP-1s. Why? Do you think it's just big pharma that's putting out all this misinformation?
All the bad stuff that's out there that you're having to fight is horrible.
It's really crazy. I mean, I had a client who's in her 40s, perimenopause, right, PCOS, was doing
like
all
the perfect
things,
candidate.
right? Was doing all the things: protein, working out, sleeping. Couldn't get her A1C below 5.8, right, and could not drop a pound. Right. Couldn't do it. And I had to advocate for her and fight and fight. Right. And the minute she got on the lowest dose of the GLP, which is what I suggested, it just started falling off. Right.
She started doing better.
She just needed that extra little bump.
And the neuroprotective stuff.
Yeah.
Right,
We're now starting to see these longitudinal studies, having these around long enough.
Right.
and some of the other health benefits.
But then that macular degeneration study just came out with a GLP-1
In diabetics.
right? In diabetics,
In
right?
diabetics, so
Right.
not in the biohacker, not in the healthy crowd.
normal crowd, right? But then we have a lot of people who are type 2 diabetics.
Fair.
But they are at high risk anyway. And I haven't analyzed that study. It just came out, and of course, everybody else came forward with that. All my patients are like, well, look at this. So you just have to fight. Like the muscle loss thing kills me. If you do not eat protein, you will lose muscle.
Right.
It doesn't matter what you're doing, right? It
You also
doesn't
have to
matter what
move.
you're doing.
If
You gotta
if you sit
exercise,
on the
you gotta-
couch thinking you're going to lose weight on GLP-1s, you might, but you lose more than weight.
Yeah. Right, so you have to exercise and
Exercise,
you have to eat, and you have to eat
protein.
protein.
Yeah, the recipe
and it's
for
hard
making muscle.
sometimes if you get the people dosed up and they don't want to eat, it's hard to get them to eat protein, right?
Yeah, I didn't want to miss this because there's some new technologies now. What's coming is designer exosomes, mitochondrial stuffed
Right.
exosomes.
That's going to be the cool thing you can do when you load the exosomes with something that you
Yeah, they've got now the Muse cells are gaining excitement. We have natural killer cell exosomes that we're starting to use to help patients with cancer diagnoses. Those are probably sort of the hot topics on the shelf right now. What do you see?
Agree. I mean, people are learning more about we had that study that just came out 2 days ago. Again, another rampant of corticosteroids.
Yeah.
It was almost malpractice for using corticosteroids,
Right.
Because it was such a dramatic worsening of arthritis in people who had corticosteroids. I don't think we adequately told people what the risks that are associated with this. I think we probably have caused a lot of harm. So if people are seeing this data come out, they're like, oh my God, this is ugly. What else I have. So people are exploring these other options. We now have so many studies on both platelet cells, stem cells, and exosomes. I think there's over 5,000 exosome studies now. My old orthopedic partners are like, well, there's no data on this. I'm like, actually, there's a lot of data on this. Actually, there's better data than your corticosteroid injections.
And just for those might be listening at home, there is still a role for significantly acute inflation.
Agree.
If you
I
can't
still
breathe
use-
or something, you need a steroid,
No.
right?
And I still occasionally use
Yeah.
joint steroid injections too, or spine steroid injections one time, right? Because I have someone who can't move. I need to just get them some pain relief. I'm not going to say I never use corticosteroids even now. I do tell my patient, there is studies that show this. I mean, you know this from your spine work. I have somebody who has an acute disc herniation and horrendous sciatica. Either I got to take them to surgery or I got to do something to control their pain right now, right?
I think it's the repetitive
It's a repetitive use, right? It's just the using
especially
these-
in
right,
the cartilage.
right.
So in the spine, we use it around
nerves, right?
Yeah,
things like that,
epidural.
right.
So it's
right. It's not as damaging.
Right. And then, of course, systemic, that's not good either. We see all kinds of issues with that, including osteoporosis and
Right.
compression fractures and things.
Glucose out of control and
Yeah.
insulin levels high.
So I agree. Getting away from corticosteroid use as much as we can and looking to natural biologic. I mean, biology is teaching us, and we just need to listen and try to tap into that more and more.
What are you using the most in your practice?
Stem cell-derived exosomes,
Yeah.
amniotic fluid.
Yeah.
Yeah. You?
Yeah, mostly exosomes. I mean, and so usually using the platelet fiber matrix and the exosomes.
Perfect.
Do you guys feel that as the outsider in the exosome world, do you guys feel that the supply chain for that, like that always is the question, right, that people ask when we start talking about stem cells and exosomes. It's like, how do we know that they're really high quality? How do we know that it's actually the same conversation with the peptides, right?
It is.
Right. It is. Yeah. There's a lot of people jumping into the exosome market now.
Right. So how do you both make that delineation between who's legit and who's not?
If the salesperson tells you their lab is the best, they're not. That's the first. But you got to vet them. You have to talk to their scientists, not their salespeople. You have to
Visit the labs.
visit the lab.
Right.
Are they certified? Because although what we're doing is not yet approved for marketing claims, these labs are certified and approved for how they prepare and handle and all that and test.
Right.
Third-party testing is always good, so it's objective. And every dose should come with a certificate of authenticity, which is usually a testing certificate.
Right.
And what do you think about the laws? So I know laws are changing in Florida and Utah. I always get concerned. I have great waivers when people want to do them IV and such. But what do you tell your patients? Are you concerned about that?
I'm always concerned that there's going to be more overstepping of those who think they understand, but we have to educate. So Congress set up the FDA to manage and oversee marketing claims so that consumers are protected. They do not approve what doctors do and don't do. They do not approve what patients receive and don't receive. That is a holy relationship, a doctor-patient relationship, where we go over all the options, alternatives, pros and cons, risks and benefits, and help educate a patient to make the best decision in what's called the process of informed consent. That's it.
Right.
Well said.
I just like to be under the radar, so I just don't.
Absolutely.
I don't know if you know this, but you're not under the
You know,
radar.
you're pretty popular, Dr. Earth. Everyone knows you. You're kind of famous.
Do we have a mirror, somebody?
This whole medicine 3.0 thing, right, has sort of blown the doors off the what is enough data to prove that the evidence is there. It is sort of an odd gray area we're in with a lot of these spaces because of administrations and things of that nature.
So it's one of the goals of like our longevity docs group. Dr. David Liu put together this just network of longevity docs. But basically one of the goals was, now you got 250 doctors, and we're all talking about what we're doing and what we're seeing, right? If I say, hey, have you guys tried this peptide and what are you seeing? And 90 docs go, I tried it, it was shit. I'm probably going to say, okay, I've got 90 people who've tried it in patients. So we're actually collectively putting our minds together. So we're in a safe space, talking among each other, hearing what other people are doing and what their outcomes are going, because that's the best data
amazing.
we have, right?
That's great.
So it's very cool. And it's really what he tried to do, is put together a place where physicians could communicate. You go to conferences and people get up there and they give their talk, and like, oh, well, that sounds great, right? And you try it and it doesn't work at all. Talks are whatever your opinion is, and you can prove anything to look good. So now when you have all these doctors and they're using them in different populations, in different states, in different countries, you can start to collectively look at what's working or how we're dosing things.
I think we all were trained, it's best to have these controlled studies and the blinded studies and the placebo-controlled studies, right? But most of our patients, we probably at this table see more physicians as patients who aren't offering this to their patients, but they know. If you know, you know. Right back to that.
Right.
So I have a feeling that we need to relook at what is enough, which is your question, data. And it would be wonderful, because I have that thread, and whenever I'm stuck waiting to pick my wife up or something, I'll get to a few hundred of them. And thank you for being active on there. I appreciate that. So we need to throw that into an AI, which is next on my list. It would be a great way to pull out the patterns. Because AI is a great pattern recognizer. It might even be better in some circumstances than most research studies that we misinterpret.
Right, the AI doesn't have any bias.
Right, and it's people's organic experiences we could throw in there and draw from that. So I think you were right. It's okay to take a bunch of N=1s and pull out the pattern.
The patterns, right. Because that's really what a research study is, right?
Absolutely.
Take out the placebo stuff. But it's really, what we want is, in most people, does this do a good job and they don't have a horrible side effect.
I wanted to bring up AI again, if that's okay. We all talk about AI. Yeah, we could throw, like a patient, throw some symptoms into ChatGPT and see what we might have. But how are we using it maybe differently, outside of perhaps writing content or helping us to organize a research article or something? How else are you applying AI or want to apply it?
Well, number one, I love it for transcription for my cases. When I'm seeing a patient, it listens in, it writes up a nice note for me. It still needs a lot of corrections, but it's saved me buku time to have AI there. I use it a lot for research. There's certain sites that are much more research-oriented. Functional Mind's great because it's very much designed to make sure all the research articles it gives you have been double-checked. There's nothing. We still deal with hallucinations as much as people say hallucination is not a problem with AI as much anymore.
Oh, it is.
It really is. I asked AI, I said, hey, I want to have like a cool little at-home study people can do, a fun little study they can do that shows some health factor. And I said, okay, have them go out in the sun and look at their shadow. If their shadow's blurry, they have low vitamin D levels. I'm like, wow. I go, and then I ask AI, I go, is this actually really true? And they go, no. I just made that up. I go, okay, well, thanks.
You're honest.
Now could you actually give me some real... I really just said, no, I just made that up. I was like, great. I thought that was so cool, but thank God I didn't post it.
I think you should.
Don't trust AI. That'd be your header, right? It's not like a perfect brain, but it's very good though. And then it will think of things I might not think of. Like I'll say, oh, use your metabolic IB. I'm like, oh yeah, I forgot about that.
It does sometimes give you things that you're like, oh, I didn't actually think about that.
That would be good. So it is helpful in that, but it's nice if you're having one of those brain fart days where you're like, I need some help today.
Yep. No, I've used it to help frame things. Final word is ours, right?
Yes.
As medical providers, but it has been helpful because it's a pattern recognizer. It pulls out things you might not think of, like you said, and it is completely horrible with references. It makes them up.
It does make them up.
Never forget to check your references.
Right. Yeah.
Okay, let's do a quick rapid fire, and we'll let you enjoy the Las Vegas sun after that. Okay, you're on a desert island. You have one supplement you can bring with you. Doctor, what is it?
Supplement, not peptide.
Supplement. We'll get there.
On desert island where I'm getting tons of sun, so I don't need my D3K2. I mean, I would say that the number one thing that's going to fix almost everything is D3K2. If I'm on that desert island, I'm probably going to say my omegas are going to fall into a pretty high category there. and then magnesium. So I would say if I'm getting tons of sun, give me some omegas, and I got to have some magnesium. Because you're going to be magnesium deficient after sweating in that sun.
We'll try
I think
that.
the good thing is on our desert island, our circadian rhythms are going to get so much better because we'll just be awake at dawn, we'll go to sleep at dark,
Yeah,
we're
no
going to be in the
phones.
sun.
Yeah, it's going to run out of power, no
So
reception eventually.
I think that's the way to be healthy. You know, is to be in the light, go to bed when it's dark.
And that's why Tom Hanks looked so good towards the end there before he got rescued. Should have stayed. Okay, now you get to take your favorite peptide or related product with you. What
I'm
is
going to
it?
bring the GLPs.
Excellent.
I think a low-dose GLP, I'm going to protect my brain, I'm going to protect my immune system. Low-dose GLPs.
Last rapid fire. So you're a rat in a study and you're in a box and you're only allowed to do one exercise. You can have whatever equipment you want. One exercise every day. What's the most efficient way to get the best workout with one exercise?
A squat.
Okay. Body weight squat.
Body weight squat.
Excellent.
Oh man, you're taking all the good ones. I mean, insert compound lift movement here.
Right. Yeah.
Yeah, I was going to say squats instead of taken. Maybe rebounding, like jumping.
Yep.
Yeah.
Yeah.
I like it. I like it. I'd probably get a treadmill with a high incline and do high intensity intervals because you're going to get good leg muscle, hard work, plus some cardio.
Get your cardio.
Poor hip
stuff in there, too.
flexors.
I cheated, right? I got cardio and muscle.
I just didn't think the mouse could buy a treadmill.
I said you could have any equipment.
Okay, can the mouse do a treadmill on two legs like that?
You need a bar, a little bar.
I resign. I want to thank every one of you for being here. This was a treat. I hope you come back. We do it again, or maybe you host next time. We'll do it by you.
Yeah.
Thank you.
So much fun.
Thank you.
Honored.
Jeff, for
Appreciate
putting it
it.
all together.
Thank you. So
job.
nice to meet you all.
It's a wrap.